everybody, it's Brett Mitchell here for Infection Control Matters, and I'm at the Hong Kong Infection Control Nurses Association conference, and I'm standing in the poster area. Always some gems in the posters, and I've got a few that I like. The first one is from Dr. Su, and this is from the PWH Infection Control team, and it's called Patient Care Equipment Disinfection Skill of Award Supporting Staff. So really what the purpose of this study was to try and evaluate and improve the patient care assistance cleaning and hopefully reduce the spread of multi-drug resistant Acinetobacter baumannii. They got the PCAs, their patient care assistants, together. They provided some training, really hands-on practical training on disinfection skills, used the UV lights and dots to provide immediate feedback. They shared where there were commonly missing areas of disinfection. And the thing I liked about this, apart from this is just using research in practice, is that there was an interesting note that there was so much demand that they had to put on an additional 24 workshops over 8 days. And they ended up with 380 PCAs attending the workshop. Now, to me, that tells me they're doing something really well. So that's just awesome. It also shows that we need perhaps to give acknowledgement to our cleaning staff, in this case the PCAs. You give them a little bit of information and support and hands-on work, and they came in droves. And it's a real credit to the team there. That must have been the way that they went about this particular training. But that to me is amazing, to be able to train that many people and have that much extra demand. The other interesting thing I found was some of the common lapses that they found, I guess areas for improvement. And that was insufficient friction force during disinfection. And that's a really important point, often something that gets overlooked and not specifically identified. And so that enough friction during that cleaning and disinfection phase. The failure to remove sticky adhesive tapes from equipment before disinfection. Disinfection is not going to work, of course, if there's sticky adhesive, particularly adhesive tapes on objects and equipment still. Not looking at the instruction cards, so just going and cleaning and not thinking about how do I clean this particular piece of equipment. And we know that each particular piece of equipment does require a particular approach, and that really needs to be taught and made available so that people know what to do for the right piece of equipment. And there's also some poor segregations of cleaning and dirty zones leading to potential recontamination. So I really like this poster, just putting research into practice and doing it so well. They had great uptake from their PCAs. Well done. Now, while we're on the cleaning theme, there was another poster from Dr. Jeet, and it was called Hospital Environmental Monitoring Program in Hong Kong SH Medical Group. And what they used was basically a UV ink stamp. So rather than the dots, they developed and used a stamp to monitor environmental hygiene, and did this in high-touch surfaces. Now, you might go, okay, we've heard all this before. And the thing I liked about this was they did it in other areas that perhaps we don't often think about. So they they included outpatient units, and in surgical settings as well, clinical departments. And so what they found, which I thought was just getting to the sort of crux of it, if you like, was that there were some areas that were commonly missed that probably don't normally get identified because we don't probably normally audit them. And some of those included the computer mouse. It's something that everyone touches, but we don't probably think to clean it that often, and we certainly don't use the UV dots that often on that area. Well, I don't. There was also nurses' station phones, and that was an interesting one. Air conditioning switches in consultation rooms, and particularly those in sort of outpatient areas. So just thinking about those other areas outside of a ward environment that might be touched frequently, air conditioning units, light switches that might turn on and off in consultation rooms when they are and aren't being used. So I like this because it shone a light, excuse the pun, on other areas of the hospital that we need to focus on in terms of environmental cleaning. And in addition to, of course, those high-risk, high-touch areas within the clinical environment. Changing tack a little bit, and my third poster It's a called Corporate-Wide Fit Testing Registry for Public Hospitals in Hong Kong by Wong and colleagues. So in short, what's been developed is an electronic fit testing registry, and that fit testing results were exported straight from port account and uploaded straight into the registry. And then this was mapped with human capital management data on a monthly basis to keep records up to date. I love this because it's a complicated, challenging process to try and keep a record of fit testing. Here's an automated system linked to what they call human capital management data, which I presume is like a HR record. And this registry offered really a standardised and friendly solution to understanding where fit testing was at for individuals. There were 220,000 fit test records securely stored. One of the interesting things is it enables the procurement team to understand what data and what respirators are best suited for staff. It also found that 12% of wearers only had one suitable model of a respirator. So when there's a shortage of a respirator, then they need to identify a new arrangement with a new model. It also allowed staff and supervisors to see at any given point in time where they were at with their fit testing and respirators. So great automated system and lots of utility for procurement as well. And my final poster from the Hong Kong Infectious Control Nurses Association conference is titled Prevalence Survey of Bloodstream Infections in Public Hospitals in Hong Kong. Kong was the lead author on this poster. Basically, this was a point prevalence survey to understand the prevalence of bloodstream infections. It was done in 2023. A whopping 17,800 patients from 32 hospitals were surveyed. And the prevalence of bloodstream infections was 1.7%, which is quite interesting. And the prevalence of hospital-acquired bloodstream infections was 0.6%. And they note that there was some slight increases on both of those figures compared to when they did the last prevalence survey in 2010, so 13 years or so prior. I found the organisms interesting, the causative organism bloodstream infections. E. coli accounted for about 35% of bloodstream infections. E. coli always seems to come up with bloodstream infections, and probably unlike things like MRSA in the past, we haven't really targeted specific organism-based bloodstream infection interventions other than, as I say, MRSA. So E. coli, major contributor, not really surprising there. Klebsiella was the next most frequent causative organism of bloodstream infection at around 13%. Thought that was quite interesting. Then MRSA at 7%, followed by MSSA at 7%, so 14% Staph aureus, and Proteus about 5%. So this is an interesting prevalence study. There's sort of conclusions here in Hong Kong that they have lower hospital-acquired bloodstream infections as a prevalence rate compared to Greece, Singapore, and ECDC countries, or countries within the European Union, but higher than that in the UK, and highlights the priority areas for surveillance. And I suspect that's specifically going to be hospital-acquired BSIs and some specific target organisms. It'll be interesting to see if they do act on that data. We've seen plenty of point prevalence studies done in the past with not a lot of action for certain main infection types. Well, that's it from me from the Hong Kong Infectious Control Nurses Association conference. Great to see all these posters, and thanks for listening to this latest episode. I hope you found some of these interesting. Bye for now.